Okay. Good evening, everyone.
Yeah, I'm sharing. Yeah, ma'am, you can proceed.
Okay. Good evening, everyone, and I welcome you all to the live session on 25 most important clinical based anesthesia MCQs for the upcoming 2023 NEET PG exams on our Medicos community platform. Medicos community platform is a new platform for PG aspirants where we will be holding a lot of uh, live lectures for you and a question bank prepared by our experienced faculty. There will be different packages available which you can subscribe to and which will be very helpful to you for your upcoming NEET PG exams. So let's begin with the session today. I'm Dr. Chris Lemos and I'm the faculty for anesthesia. So let's begin with the first question. A 40-year-old male patient has been rescued from a house fire. He is hemodynamically stable but has cherry red appearance of the skin and is suspected to have carbon monoxide poisoning. Which would be the best device to detect the carboxyhemoglobin? You have four options. Option A is co-oximeter, option B is pulse oximeter, option C is capnography, and option D is fuel cell. So the correct answer for this question would be option A, which is co-oximeter. Co-oximeter is a device originally by the Massimo company, which is useful in detecting all the abnormal hemoglobin because it has 4 different wavelengths to detect the abnormal hemoglobins like methemoglobinemia, carboxyhemoglobin. If you look at your traditional device of pulse oximeter, it only has 2 wavelengths. One is your infrared and red light, 940 nanometers and 660 nanometers. But if you look closely into the diagram that I have just displayed, it shows different wavelengths for hemoglobins like sulfhemoglobin, methemoglobin, carboxy. So co-oximeter would be the correct answer since it can actually detect the percentage of carboxyhemoglobin. Option C, which is capnography, is a device used to measure expired tidal volume of your carbon dioxide. And fuel cell is an oxygen analyzer usually used on our anesthesia machines, which is kind of made sure that we give correct amount of FiO2 to the patient and the patient is not getting hypoxic. So I repeat again that the correct option here would be a co-oximeter. Coming to our next question. What is the confirmatory sign of correct placement of endotracheal tubes? Option A, pulse oximeter. Option B, auscultation of the chest and epigastrium. Option C, capnography trace. And option D is arterial blood gas. Talking about option A, which is a traditional pulse oximeter, that is usually used to detect the percentage of oxygenated hemoglobin in your arterial blood. Now bear in mind, even after the endotracheal tube might be in the esophagus, the pulse oximeter has a little bit of lag time. So even if the patient is hypoxic, it would only tell you after a few seconds. Option B, auscultation. It's a traditional clinical method to auscultate 5 points, the 2 upper zones, 2 lower zones and your epigastrium. However, in conditions like obesity or if your patient has some pulmonary disease like COPD or emphysema, it might not be very well heard, like the breath sounds won't be very well heard. So although I would say traditionally it used to be a method, it's not a confirmatory method anymore. Capnography, this is your gold standard method to detect the correct position of your endotracheal tube.
Hello.
Hello, yes.
Yeah, ma'am, sorry to disturb you. Actually, ma'am, can you come back to that op software? Actually, we are receiving, I can say, particularly low a voice.
Yes, sir. Yeah. What do I do?
Hello.
Hello. Yeah. What do I do? Can you hear
Hello,
me?
yeah, ma'am, please come back to
Yeah, I'm on op software.
op software once.
I am on op software.
Actually, I can't see the screen of that ops.
Can you see this screen?
No, no, I can't see.
Okay, I'll stop and start presenting
Sir,
again.
can you see the screen of op software? Okay, okay, okay.
Okay, I'm presenting it again. Uh, there you go. Can you see it now?
Yeah, yeah, please present.
I am on the op software screen.
Wait. Yeah, okay. Mic. This mic is fine. So, ma'am, can you use, I can say, microphone?
Uh, I don't have one which will go to the lightning port of my laptop, but I can get headphones or something.
Or else, yeah, yeah, yeah. Yeah, ma'am, you can put that. AirPod.
Yeah, I don't have it right now. I, my voice was pretty good yesterday, so I thought I could just use it without the.
Okay, okay, okay. Then you proceed ahead. We will check.
Okay, I'll just carry on from that question.
Okay. Proceed ahead. We will check.
Okay, so option C was capnography trace, which is your correct option. It is now considered the gold standard method to detect the position of your endotracheal tube. But what you have to see on your capnography is 4 or more square wave sustained patterns. That is, even esophageal intubation might show you some form of capnography trace. However, it won't be like a proper square wave pattern. It would be just be wavy waves like this. So a proper square shaped pattern is what you need to see on your capnography, which is a gold standard technique. And your option D was arterial blood gases. It is just mainly to detect the partial pressure of your oxygen, carbon dioxide, your pH and electrolytes and so on from the arterial blood. Here are different capnography waveforms in case you're given a visual in the examination. If you look at the first waveform, that's a pretty normal standard square wave pattern. EtCO2, which is your end tidal CO2, is between 30 to 40 range, which is normal. The normal values are 35 to 45. Coming to this pattern, there are only two big waveforms seen and they're quite large. So this is suggestive of hypoventilation. Coming to your option C, here you see many smaller traces and the value is below 30. So this is indicative of hyperventilation as the patient is breathing quite fast. Coming to this image, you see one square wave pattern followed by...
Yeah, sorry for the intervention. Sorry.
Yes.
Sorry. No, the thing is, Sagar, in the mobile device, the voice is very much low.
Yeah, yeah, I can feel this.
Yeah, that makes a lot of sense because most of our users, they don't see in the laptop. They use it to see in the mobile phones. Am I correct?
Yeah, yeah, yeah.
Something, this one, what I can see is in the laptop, it is okay. We can adjust with that. But with this one, mobile devices, it is very much low even if I fix the earphone. What is the issue, Sagar?
Yeah, I can feel the same. Yeah. Particularly, that's why I have told ma'am to use I can say a microphone or a headphone.
Yes. And doctor, this shutterstock.com .1 now 19167, this credit needs to be removed.
I'll edit it out.
Then you have submitted the PPT already for editing.
So I did this at work. I'm just seeing that the baseline came up. I was going to highlight over it.
Okay.
I'll highlight over it.
Sure. So doctor, there is an issue now. Sagar, what you can do for this?
So do I
Actually, sir, we need to add a microphone to this or a headphone mic while this.
Yeah. So doctor, what you can do?
Yes, sir.
The thing is, your voice is there now. We are hearing it very much low. In the volume is very much low in the mobile devices actually.
Okay, sir.
Sagar is saying either to use the microphone or something like that.
Yes, sir.
Can you use it?
So I'll just get. I have
Yeah.
AirPods, sir, but the problem is suddenly they just discharge. So I don't want to use AirPods with the laptop, and I'll have to get one which is compatible with this MacBook.
You can check. We shall check that. Not an issue. Bring that.
Okay, can you give me 5 minutes? I'll just get it.
Sure, sure.
Yeah,
Yes,
thanks.
yes.
Hello?
Yes, yes.
So am I audible?
Yes, yes, you are clearly audible. But the proper thing is backend is not adjusted properly.
Yeah, I'll just do it. Hello, is that better?
Yeah, yeah, it works.
So should I continue?
Yeah, you should continue. Wait for a minute.
Okay.
Yes, proceed.
Yes, sir. Coming to the to this diagram, where you see sort of a shark fin pattern, that is, there is some upsloping in this plateau phase that is usually seen in lower airway obstruction in asthma, COPD, or even bronchospasm. And the last trace is where there is no proper morphology or shape to the waveform. That indicates esophageal intubation, where it is just a swallowed air that comes off in a haphazard trace. So coming to question number 3, a 2-year-old boy is undergoing ENT surgery. Which of the following anesthetic agent cannot be used for induction of anesthesia? So the key word here being cannot. Sevoflurane, as we know, is the preferred agent of choice for pediatric inhalation induction. As it's a very sweet smelling gas, it's completely non-irritant to the airways, and overall the incidence of cardiovascular instability and arrhythmias, especially when you infiltrate local, is quite less with sevoflurane. So sevoflurane is in fact preferred. Nitrous oxide, we know that it is used as Entonox, which is 50% oxygen and 50% nitrous in labor analgesia. So it can be used for induction as it reduces the dose of other inhalational agents due to an effect called as second gas effect. So it can be used. Halothane, in the past, halothane was the anesthetic of choice for pediatrics, again because it's very pleasant smelling. However, nowadays it's almost out of use, and back then, due to recurrent exposure to halothane, there used to be a condition called as halothane hepatitis, and also it leads to propensity of the local anesthetic reaction with halothane causes arrhythmias. So it's not used any longer. So the only option which cannot be used in pediatrics is desflurane. Desflurane is a very pungent gas, and because it's pungent, it tends to cause laryngospasm and therefore not preferred for induction of anesthesia. Then coming to question number 4. So you are called to the labor ward to assist the anesthetic registrar to prepare epidural infusion. Which of the following drug combinations are preferred? So for an epidural infusion, we need a drug combination which will give pain relief to the patient. So first option is bupivacaine and fentanyl. Option B is bupivacaine and neostigmine. Option C is bupivacaine and epinephrine. And then option D is bupivacaine and ketamine. So out of these options, the best answer would be bupivacaine and fentanyl. That is because bupivacaine is a local anesthetic from the amide group. Fentanyl is an opioid. Both have analgesic properties. So if both are used together, they give an additive effect. So you will need very less concentration of your local anesthetics. And also the bupivacaine gets diluted. So ultimately the concentration that you end up using is just 0.125% plus 2 micrograms per mil of fentanyl. Now what it achieves is you only get sensory blockade, that is you achieve analgesia. Therefore, after getting your epidural top up, the pregnant patients who are in labor, they can actually mobilize, which can help in progression of the labor further. And side effects with local anesthetics like hypotension are avoided when you use a smaller concentration. The other options that were given is bupivacaine with epinephrine. So epinephrine is generally used in your regional nerve blockade or your subcutaneous infiltration, which reduces the systemic absorption of your bupivacaine, not very preferable for epidural. Neostigmine, although theoretically has been used for research purpose, it is not used in epidural. This is your reversal agent, anticholinesterase drug. And ketamine is an IV induction anesthetic agent. Only preservative-free forms have been used for spinal anesthesia, not a very preferable drug for epidural.
Yeah, wait for a second. Whether are you using this one, what you call, trying to use a pen tab?
So I am not trying to use because there is a lag of the pen tab when I use this Notability app with the OBS software. Just on its own it works very well.
Pardon? What happened?
So this pen tab with my Notability app works very well, but once I am on the OBS, it shows a bit of lag. Like if I'm trying to write, it shows a bit of lag. So I'm just using it as a pointer.
Okay, okay. But we need to find a, do you think whether we are supposed to find a solution for this?
So the OBS software just showed up that maybe it will give me an upgrade. So when I restart my laptop tonight, I think I'll just upgrade the app.
Sagar, are you there?
Yes, and
Sagar, she is feeling some, this one, what do you call lag while using that particular pen tab. So she is saying that she will be upgrading the ops. So
Would
will
that work?
upgrading the ops, I think it
no,
will be
no, no,
face some issues.
no, it will not work. It will not work.
Yeah. We don't think
The
that
thing is that, ma'am, yeah, yeah,
upgrading the ops will not work, na, sir.
yeah, yeah. So if it's lagging now, it's because of the processor, ma'am. Like,
Okay.
yeah, like the thing is that now you are doing a, I can say, heavy RAM usage, na, that's why.
Okay. Because it works very well when it's not connected to the OBS. I tried it today, it
Oh,
works well.
I can understand.
Yeah.
I can
But
understand.
OBS is very sensitive software, na, doctor.
So I don't know why it is happening. I just like made an
No, the
observation
thing
that.
is, no. The thing is, ops software is very sensitive.
Okay, okay.
Yeah, that is the reason we can see the lag over this particular software.
Okay, sir.
Am I correct, Sagar?
Yes, definitely.
It is a very sensitive software, ops.
Mm-hmm.
So that we can find, we can come to know each and every lags or something like that.
Yeah.
But doctor, just try to tick the correct answer, something like that. You try that.
Uh, so like I tried to do a check mark and it just came across as a line.
Acha. We can understand that. Just round up the things. Is it possible?
Sorry, round? Yeah, I'll just try.
No.
So it's not.
Yeah. For this time, better you use as a pointer.
Yes, sir.
You don't take a chance. Let us see what.
Yes, sir.
But we need to work on this area, Sagar. We need to find some solutions for this.
Yeah. Also,
But,
ma'am, can you try with the, I can say like the touchpad of the laptop?
Yeah, I'm just doing this. It's difficult to put. I can just do like a line or something with it, or just underline. This is with the touchpad.
yeah, it works fine and it follows your command type.
Okay.
You check with the. Can you write with that? Check.
So with the just the trackpad,
Yeah.
uh, so there is still a bit lag. No, it's very difficult.
No. It doesn't work. It doesn't work. Focus for no. Better you use as a pointer. You need to get used to that.
Okay, so do I continue?
Yeah.
Okay. So question number 5, which of the following drugs should be avoided in the patient with history of malignant hyperthermia? And your option A is etomidate, B is propofol, C is succinylcholine, and D is thiopentone. So the correct answer here is succinylcholine. Now, malignant hyperthermia is a rare autosomal dominant condition. It's due to the abnormal ryanodine receptor, which is situated on the sarcoplasmic reticulum of the muscles. And what it does is, when it gets activated, it releases massive amounts of stored calcium, which leads to muscle contracture and rigidity. Now, this generalized contraction rigidity will lead to hyperthermia, excessive heat generation, metabolic acidosis, and hyperkalemia due to excessive contraction. Now, the easiest way to remember the triggering agents is it's all your volatile agents, volatile or inhalational anesthetics, and just one group of muscle relaxants. That is your depolarizing muscle relaxant like succinylcholine. So from the options here, rest of the other three drugs, your etomidate, propofol and thiopentone, all are IV induction agents except succinylcholine, which is a muscle relaxant. Question number 6, that is the most common cause of perioperative visual loss is A, retinal embolism, B is angle closure glaucoma, C is ischemic optic neuropathy, and D is corneal abrasion. Now, perioperative visual loss is a very upcoming topic because it has now been recognized as a valid side effect or adverse effect of anesthesia and positioning. So, let's have a look in detail. As I said, it's a very rare adverse effect but quite a debilitating one. So, the risk factors are especially for patients who undergo any surgery in the prone position. When you lie prone, there might be some pressure effect on the eyes. Then pre-op, if the patient has history of hypertension or diabetes, if the surgical duration is quite long, if there has been any hypotension in the perioperative period or hypervolemia. And your most common cause for this is your ischemic optic neuropathy. That is due to hypotension, ischemia to the optic nerve. And it is usually seen after spinal surgeries like longer spine fixations and after the patient has been on a cardiopulmonary bypass machine for any cardiac surgery. So again, the answer here is ischemic optic neuropathy. Moving on to the 7th question. So all of the following are colloids except option A is albumin, option B is gelatin, option C is plasmolite, and option D is hydroxyethyl starch. So the correct answer here would be plasmolite, also known as the balanced salt solution. Now, plasmolite has also been recently introduced in India, although it has been used in the West. The best part about it that it is very isotonic. Isotonic as in the osmolarity is very similar to that of the plasma, which is 294 milliosmoles per liter. It has sodium at 140, which is less than your normal saline, which has sodium at 154, potassium at 5 milliequivalents per liter, chloride is 98 milliequivalents per liter, magnesium is 3, acetate and gluconate are also added to this. So it's very balanced salt solution because it has all the constituents which are like your normal plasma. Now, colloids are known as plasma expanders because once they are in the body, they stay in the blood circulation for at least 4 to 6 hours. The types of colloids would be blood derived, which is most commonly your albumin and other plasma protein fractions or your fresh frozen plasma, and other semi-synthetic substances like dextrans, gelatin or hydroxyethyl starch. So all the other options are colloids except plasmolite. Okay, moving on to our 8th question. Which of the following anesthesia breathing circuits is best suited for children? Option A is Mapleson A, option B is Mapleson F, option C is Mapleson B, and option D is Mapleson D. Looking at the Mapleson classification, if you look at your Mapleson A circuit, it has bag on the anesthesia machine end, and on the patient end it has a APL valve. If you look at Mapleson B, the fresh gas flow which is away at the machine end has jumped right across near to the patient end in the Mapleson B. In the Mapleson C, the corrugated tube is missing. In the Mapleson D, it's mirror image of your Mapleson A, that is the APL valve has moved back to the machine and the fresh gas flow has moved towards the patient. Mapleson E, or also known as Ayer's TPs, here you have your entire APL valve and your bag cut off. So it's a very open, semi-open circuit here. And Mapleson F, which is also called as the Jackson-Rees modification of Ayer's TPs, is what they have done is they have just added an open-ended bag at the machine end. And therefore, we'll look at which circuit is best suited for children. So Mapleson F, or the Jackson-Rees modification, that is the correct answer. It is usually preferred for children up to 20 kilos of weight, and it is the circuit of choice in spontaneous ventilation. Although the fresh gas flow that you would use here is 2 to 3 times a minute ventilation. But because of the open-ended bag, it makes it very safe for ventilation in pediatrics because it avoids development of barotrauma. Another linked MCQ to this that could be asked is your efficiency of Mapleson systems. So for your spontaneous ventilation, the best circuit would be Mapleson A, followed by D, F, E, and then last would be your C or B. And for controlled ventilation, the best preferred ones are D, F, E, followed by B, C, and then Mapleson A. It's the other way around. Coming to question number 9. All of the following is true about a pediatric airway except option A, they have a large occiput. Option B, they have macroglossia. Option C, they have a small epiglottis. Or option D, they have a high larynx. So talking about features of the pediatric airway, they have a very large occiput, and therefore when you are intubating small children, you need to keep a drape under the shoulder compared to under the head when we use it for adults. So the difference here is the drape would go under the shoulder for pediatrics. They have a small mandible but a large tongue. Therefore, there is a risk of tongue falling back when relaxed and obstructing the airway. They have a very large floppy epiglottis, which is also called as omega-shaped epiglottis. Now that large floppy epiglottis is very difficult sometimes to move away from your vocal cords. The larynx in children is at a higher level compared to adults. So between C3 to C5, compared to adults, it's at C4 to C6 levels. Narrowest part of the larynx is your subglottis, that is below the vocal cords, compared to adults where it is at the glottis level. Now here you have to keep in mind, if you can see the glottis, that is your vocal cords, and you feel that size number 3 or 4 tube can easily pass through, sometimes the tube might get obstructed beyond the vocal cords. So you always have to be mindful about it. So the answer to the question was small epiglottis. Rest are all features of your pediatric airway: large occiput, macroglossia, and higher larynx. Question number 10. Volatile anesthetic agent which undergoes highest metabolism in the body is A. halothane, B. isoflurane, C. sevoflurane, and D. desflurane. So this table is taken from Miller's anesthesia textbook. Here I have put it in the order of least to most metabolism. So the answer to the question is halothane. So nitrous oxide almost undergoes zero metabolism in the body percentage wise. Desflurane also least metabolism, 0.02%. So this is in fact preferred in obese patients undergoing anesthesia and especially long duration of surgeries. Isoflurane undergoes 0.2% metabolism. Enflurane is at 2%. Sevoflurane is 2 to 4%. And halothane undergoes the highest amount of metabolism, which is almost 25%. So that is why coming to the previous MCQ where I mentioned that halothane had a side effect of having halothane hepatitis occur in patients. That is because halothane used to get metabolized in the liver. Okay. Coming to our 11th question. In a patient with history of temporal lobe epilepsy, which of the following drugs should be avoided? So the key word here is epilepsy. Although they might put it as temporal lobe epilepsy, majority of your epileptic foci in the brain originate from your temporal lobe. But you have to focus on the key word, which is epilepsy. So which drugs would you be avoided in epileptics? A. Propofol, B. Thiopentone, C. Etomidate, and D. Ketamine. So propofol, as we know, it decreases your cerebral blood flow, decreases the cerebral metabolic rate of oxygen, and is an anticonvulsant. In your status epilepticus pathway, when everything fails, you just give the patient general anesthesia and you can induce them with propofol. And it is also used for burst suppression of the EEG in refractory seizures. Burst suppression, as in you give such a high dose that you achieve isoelectric standpoint on your EEG. Thiopentone has also been used in the past for refractory seizures or refractory raised intracranial pressure. It is also an anticonvulsant and reduces the metabolic rate in the brain. Now, etomidate, another induction agent, is the correct answer here because it actually has the potential to produce epileptogenic spikes on the EEG. And actually, when the patients undergo surgery for epilepsy with intraoperative EEG monitoring, if the surgeons cannot see any spikes to locate the epileptic foci, the anesthetist sometimes actually give a small bolus of etomidate to induce these spikes. Now, ketamine can be considered with dual actions. So when we use it in very low sub-anesthetic doses, mainly the sub-anesthetic doses are used for analgesia. So it can induce some spike patterns on the EEG. However, nowadays in anesthetic doses, that is 2 milligrams per kg, it is actually used to control refractory seizures in an infusion format. So out of all these 4 drugs, the best possible option to answer would be etomidate. Coming to question number 12, 45-year-old patient with history of hypertension is posted for laparoscopic cholecystectomy. Which of the following antihypertensives should be omitted on the day of surgery? And the options are, option A is amlodipine, option B is bisoprolol, option C is ramipril, and option D is furosemide. So in your Miller's textbook of anesthesia, they say that elective surgery should be delayed if your systolic blood pressure is over 200 millimeters of mercury and diastolic BP more than 115 millimeters of mercury.
Yes.
Now,
Doctor, sorry for the interference. Come
yes,
back to options.
yes, sir.
Sagar, do you need to say anything related to technical aspects? I will proceed with the other aspects later.
Yeah, sir. No, sir. You can continue.
In the sense, you said there was some lags, tiny lags, it was observed, I feel.
Yeah, I feel that, but after some time, I
But
it
thing
was
is,
fine.
it is manageable, right?
Yeah, it is manageable.
Okay. So, doctor, the thing is, can you repeat me the introductory part which you have said while starting this particular session? Introductory part, I'm saying.
So just the introduction about Medico's community.
Yeah, what you said. Yeah.
So I just said it very spontaneously. I'll just say it again. Hello everyone, and I welcome you all on the YouTube live session on a Medico's community platform. Today, I'll be discussing 25 clinically important questions in anesthesia. Medico's community is a platform for the for NEET PG aspirants, where we will be developing. Yes, sir.
For whom it is a platform for whom you are saying?
So I said NEET PG aspirants.
But you are aware that exam pattern is supposed to change from NEET PG to national, etc.
National exit. Yes, sir. So
So
I'll put it next. Yeah. I'll just write.
no, the
Yes.
thing is there is some things which you needs to be we need to clarify you.
Yes, sir.
In your landing image, it will be written as for NEET PG 2023.
Okay, sir.
In the sense, we are saying that this particular 25 top most important clinical MCQs is for
NEET
NEET PG
PG.
aspirants.
Yes, sir.
But while giving the interaction,
Yes,
no,
sir.
while giving the introduction to our platform, the early bird offer is for national exit test.
Okay. So I'm just noting down the points.
Yeah. In the sense, it should not be like early bird offer we are giving for NET PG
So
2023. It's a
for
nonsense stupid talk.
national exit test. Yes, sir.
In the sense, the introduction is there. Now, what I felt is, Dr. Chris, you are having a very good grip over the particular subjects. I can understand that. But as the session, what you call is for live interactive session, you have already mentioned the answers in the slides. So
Okay,
before
sir.
you slide down to the next slide, better you have an interaction with the target audience.
Okay, okay, sir. Okay.
Like, students, can you say me the answer before I proceed ahead? Something you should be interactive.
Yes, sir. Yes, sir.
And that is why I have asked you to start with the introductory part once again. Like, you said hello everyone, and you're Dr. Chris, and you're from medicos community, and you're their educator for this one what particular anesthesia subject. You're the educator, and you are supposed to proceed ahead like something like, before we proceed ahead with our first question, I wanted to say something regards to this medicos community,
Okay, okay,
which
okay,
is
okay.
you are whether you're taking a note, you want to take
So,
or not.
I'm doing it simultaneously. You can proceed.
Yeah. Before I introduce something, before I proceed ahead with this today's first question, I wanted to introduce something related to medicos community. Students, you are all aware that National Board of Examination, it is going to, or we expect that this National Board of Examination is supposed to introduce the National Exit Test pattern. So that what we expect is 60% of clinical questions in that mode of examination. So medicos community is introducing all courses based on national exit test pattern. So that
Okay, sir.
early bird offer is already live in the medicos community website. Please grab the opportunity and make best use of these opportunities which are provided right now. Something you take in that fashion.
Yes, sir. Yes, sir.
And you should introduce very important point that your session is also supposed to happen on 23. Here we are
23.
not discussing all 25 questions.
Okay, okay, sir. So I'll say
Like,
that in the beginning only.
in the sense after the introductory part, but before the first question.
Okay, sir. So,
You
yeah.
should say those important aspects that this particular session, like we are discussing 13 or 14 days. How
Yes,
much you
sir.
are discussing?
So 13, right? Everybody has
13.
done 13, yeah.
Yeah.
Okay.
Yeah, even radiology it was 15. If you want 15, you can do, but the
Okay, sir.
time limit is something like that, okay?
Okay, okay.
Because we have an issue with the Google Ads to promote actually.
Okay, sir.
Like what happens is if the video is very much long, we face the rejection from the Google Ads, so that it has been classified into 1 hour, 1 hour, something like that.
Okay, sir. Okay, sir.
So you want the 15 questions, the time limit remains the same. If you want the 13 questions, the time limit remains the same for this session. Okay.
Okay, sir.
What you wanted to say is after the particular introductory part, you
Yes, sir.
want to say that this particular session has been classified into two parts. Like students, we are going to discuss 13 questions in this particular session, and we'll be discussing rest of the 12 questions on 23rd
Feb.
February at 45 p.m.
Yes, sir.
So shall we proceed with the first question? Like that, you should take off. Like
Okay, sir.
the thing should
Interactive.
not. Yeah, it should be very much interactive because the product is also based on the interactive sessions only.
Okay, sir. Okay, sir.
And while you begin the things, like whether I am clearly audible and visible to everyone, so that can you give me the thumbs up? Something you should take off like that.
Okay, sir.
It should not be something. If it is a recording session, yeah, we can do the multiple tries. There will be no issues with that. But here, as you are going live at a time, you should be aware that you should be interactive. Even though you may not expect such a huge audience for this first sessions and all, it should not be something. There should be an this one what you call compromise with the qualities.
Yes, sir. Yes, sir. Okay.
Because when we promote in the future days, number of audience it will be going to increase and everyone will see the Dr. Chris.
Yes, sir. Yes,
So
sir.
that it should not be something like Dr. Chris is not interactive.
Okay, sir.
And you should keep your phone in front of you and you should this one what you call have have that particular WhatsApp,
The
and you should
lives.
have that
Okay.
particular, this is what you call, you should go for this Medicos community YouTube channel,
Yes,
and you
sir.
should check with the live session chat box.
Okay, okay, okay.
And but there, one thing you should keep in mind, that
Yes, sir.
that Medicos community's YouTube channel, while you are seeing the chat box, you please mute down that particular volume of
Okay.
that YouTube channel. Okay, otherwise you will hear your own voice.
Okay, 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 sir.
And one more thing is, you should have an eye on chat box. Very that point you should remember.
Okay,
Mm.
okay.
And the thing is, I can say that Dr. Chris can improve in the future a lot.
Okay, sir.
Hope scope for the improvement is always there. There are areas to improve, I can see that, but I can say that you will be improving in the future. Okay.
Yes, sir.
uh, Please wait for a minute. Yeah. So, any more doubts if you are having from the part of your interactive session, whether you have anything to ask with me, or the technical part, you can ask with the Sagar. If you have any doubts, you can go ahead.
Okay, sir. So just to summarize, so I come on, I say hello, I say that everybody can hear me well. Then I introduce Medicos community, and I also say that we are doing a next live session on 23rd at 8:45 p.m. And meanwhile, I keep that chat live box open on the phone, like
Yes.
visible,
Yes.
and yeah, and then I proceed with the questions. Okay,
Yes.
sir.
And the thing is, you should, your back screen is there, na, that chroma screen.
Yes, sir.
That should be adjusted properly. Even though
Okay.
I can see that the adjustment has gone right.
Okay.
Like what I wanted to convey you is that should be proper till the session gets ended.
Okay, sir.
And the settings should not be interrupted in the meantime, anywhere in the meantime of the session,
Okay. Okay.
because those shows the quality of the particular platform.
Yes, sir.
And one more thing, anything, Sagar, you need to say? No, right?
Yes, no, no.
Hopefully, I have said all the points, I feel. And don't use the telephonic conversations anywhere. Like I said to Mohan Babu, and hopefully you remember that you were there at that particular time while I was saying something like telephonic conversation. Whether you were there?
So I just joined the meeting.
Yeah. Thing is, for one of the faculty, I don't want to say the names and all. The thing is, what she did is she have used the telephonic conversation when the session was lag.
Okay.
So what I wanted to convey here is, anywhere you don't use the telephonic conversation when the session is lag, even with us, or even it may be any third party call, or it may be patient's call, anything.
Okay. Okay,
In
sir.
a sense, obviously, while you are entering these particular sessions, obviously you will be giving the duties to some parties and all. You will be coming, I knew that, but still, what I am saying is, telephonic conversation you should not use when the session is live. You
Okay, sir.
should have the conversations only via WhatsApp,
Okay, sir.
and you should keep this particular phone in the vibrating mode,
Yes, sir.
because when you use this particular telephonic conversation, our editing team will have a more duties.
Okay, sir.
Like we need to spend nearly 2 hours to edit that, or 2 days to edit that.
Okay, sir.
And once again, the thing is, if any major part, like something like if this what you call slide is not getting scrolled out, anyhow you are not using the pen tab, so that you may not face that issue. So if that is the case, if any minor issues, or if you go wrong, any minor problem or minor issues, if you have did with the concept, you can correct that. It is an interactive session. You say sorry
Okay.
and you can correct that. Okay,
Okay.
that is not a major mistakes at all.
Okay.
And what you should remember is, if major aspect like the PDF it is not getting scrolled out to next page, or you face a buffeting with your YouTube live session, if any major issues, if it happens, Sagar will be disconnecting, team will be disconnecting in the back end, and once again we will take the what you call will be retake the particular session. In a
Okay, sir.
sense, retrial needs to happen, but at any cost we need to finish the session, because we don't have the much time.
Okay.
And already there is 2 postponed sessions with the other faculties. I
Okay,
need
sir.
to we need to reschedule the classes once
Yes, sir.
again,
Yes, sir.
because the NEET PG is supposed to happen on March 5th. If the date is finalized, almost the date is finalized, and it
Yeah.
will not happen, but still If the March 5th, if the thing is supposed to happen, then we can't reschedule any classes at that this time. Okay.
Okay, sir.
And obviously, we should launch the product in the to the market, and obviously, we have some of the objectives to follow.
Yes, sir.
Hoping you know that. Okay.
Yes, sir.
So keep these points in your mind, and you'll go ahead. That's it.
Okay.
And in the things, if any minor problems, if it happens, you don't get anxious. Just be smart in front of that particular session, and just end the particular session smartly. That's it.
Okay, sir.
So
Um,
hopefully, yeah. Any doubts?
Sir, if any technical problems, would I like I would not be seeing the OBS screen. I would be on my main PDF screen. Like
Yeah, that is
I would
fine.
be notified by WhatsApp or something, right? That in case I need to stop or go back or something.
Yes, yes, yes. That is
Yeah.
what I'm saying. You will be notified in the WhatsApp.
Okay. Okay.
Even if we give the call, that particular telephone, it should be in the vibrative mode.
Yes.
Okay.
Yes. Yes. Sir.
And you don't receive the call, just check the telephone is what we are saying.
Okay. Okay. So got
In
it.
the sense to check the WhatsApp only.
Yeah.
So if that is such a major error, then Sagar will be disconnecting. Anyone, they will be disconnecting the session and will be recalling to the Google Meet.
Okay. Okay, sir.
So the thing is, the conversation is via WhatsApp, but don't use the telephones.
Okay.
In the
Okay.
sense, don't receive the call or don't talk to us even unless and until we say to receive the call
Okay.
via
Okay,
WhatsApp.
sir. Okay, sir. Okay. 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 Got it.
Yeah. So Sagar, please be stay on the line. Sagar, stay on the line, and Chris, hopefully for the time being, you can leave the meet, and by tomorrow you will be getting the mail at what time you are supposed to meet us.
So, so if this PDF has not been edited yet, can I add one more question and then send you the final in 15 minutes?
You want to add one more question? Like, what is the question number you are having in
So
this?
I have 13. I can add one more just in case.
15.
So do
It's
you?
already no, it's already 15, right?
So I think I sent 13 questions total. I after adding all the answers and everything.
Oh, okay, it's fine. It's 13, nah, it's fine. Why
It's
you
fine.
wanted to add one more? Yeah,
Okay.
it's fine.
Okay.
You take the like, if you want the such a standard, then you add two more and you finish it in 1 hour. Hopefully, it will not be fast.
So and that image which had the name on it, I wanted to actually draw the image and put it. So should I just do that 10 minutes
I
editing
don't.
and send you?
No, I think what I feel is better we do 13 plus 12 for our session.
Okay.
You take those 12 questions in the 23rd session, February.
Okay. Okay.
Because something like 14 plus 11, I don't think it will be proper. I think, or else you should go with 15 plus 12.
Okay. So
Better you don't take a chance, you explain something on February 23rd. That will not be an issue. Okay.
okay, sir. So would the same the same presentation that I've sent, would that be edited or do you want me to change that slide which had the name on it?
Name, what name?
The one of the image had a name on it because I intended to draw and put my own slide on it.
That is Shutterstock, something it is written, I feel.
Can I draw my own diagram and put it and just send it?
Sagar, are you there?
Yes.
Sagar, show the diagram. Show the diagram to Sagar.
Yeah.
Shutterstock, yeah, he will edit that.
Where is it? Uh, so it's the capnography trace. Sorry, I'll just show it. This, I don't know why it's scrolling so fast. Sorry.
Not an issue.
This, oh my God. This one.
Yeah, ma'am. Which one?
So just the name which is on the bottom.
Okay. Okay. I will take care of this.
Okay. Thank you.
In the sense, Sagar, that please do to note that where it is, that shutterstock.com is there, not and that number.
Yeah.